according to the size you will have to purchase. Even then, when it comes, you will have to contour it. You have to contour in the mouth and make it fixed, and in the bone you will have to make some holes to induce bleeding, because you need the mesenchymal stem cells to come in, then become a osteoblast, which will bound onto this the graft, and it will convert this also to the native human bone. This is a human bone, the native bone of that particular individual. Okay, now again, the edentulous ridges can be classified as the resorption. This is the upper resorption, like A, B, C, D, E, they are classified. That's the upper arch, this is the lower arch. That is from this. When it comes to the D, it is completely resorbing even the basal bone. Otherwise, all this crustal bone will be lost and will come to the basal bone. When it is the last stage, you have seen the CD patients where it is flat. You don't have any retention anymore. That will be in the vertical as well as in the horizontal. So that is the mandibular area. Okay, and the bone quality, you know that D1, D2, D3, that is a Karl-Misch classification, that is more than enough. Okay, now that's the theory part. I just rushed in because this was, let me show some cases which I have done. I think it is cases only. Extraction socket type case is a ST1 type of case where you have good amount of bone on the buccal side. Yeah, this is I think this is a last minute presentation, so I don't know what slides is coming. This is a straightforward case. This is a very straightforward case. Bone is there. The tissue, a little bit of tissue has gone up. That's all. You didn't even lose that much of papilla. You can even regenerate the papilla. So that is an aesthetic zone. So I just put it there. And that is the edentulous area. Patient also had. This is from other presentation. Also had missing in the lower. And that was the OPG. You have some little bit of crustal loan, maybe ST1 or ST2, and that is you can see the upper one, that is a drill, and that's the implant place. I mean, when you have adjacent two teeth together, you will always be in parallel. Your parallelism will go when there is no reference. So that's why you are always asked to keep the paralleling pin and then go to the next. If you have two teeth, I mean, next to each other, then I don't think so. The parallelism will go wrong. So even I didn't go wrong because of that. So it worked. So, and that is the kind of processes. So if you get, I mean, so don't be in a hurry. When you, especially in the aesthetic zone, it is mandatory that you give healing screw, wait for some time, let it wait, let the keratinized tissue heal, keep the, you know what happens is, you might have, you have your stock with you, your healing screws, everything you would have put. I'll put it in that medical box, Monday, Tuesday, Wednesday, like that. I'll pick up. That's a good idea to keep if somebody wants to use that. I'll buy it in online, and for each implant, I will put it like that. But the problem is when you land up seeing the patient, you might not have the healing screw of that size what you want, maybe small. Then you will end up putting that small implant. So you will get such a small emergence problem. Then you'll be forced to give them, because you're all busy. In the busy practice, then again you don't want to call the patient. So when you have to do it, certain things you will have to, especially in the aesthetic zone, you cannot compromise on that. If you want a wider cervical region, you will have to keep a wider healing screw. So that is something which, so this is okay. I think this is too bright. The LED screen, laptop it is okay, but it's a pretty good aesthetics. Patient, nobody can make out that it is a crown. So that is this premolar is a crown, and you can see that we didn't lose the papillae and we didn't lose the aesthetic zone, I mean the zenith as well. So we were able to recreate it, and even the molar, see the molar looks pretty good. So that's a very straightforward case. This is a girl, and this is how she was looking. And this is again the case report 2. I think that's again an immediate extraction. You can see a fracture here. This was a fracture of the central incisor. That is what the patient is already having a crown and a root canal treated. It fractured and it little bit immobilized, and you can see a space there. And this is how it looks, and this is how it is, the crown. And I've extracted it, and this is mandatory, as Sir said, rightly said. For implantology, gone those days where you use your forceps and do buccal and lingual traction. Never do it. Even if patient is not doing implant, I would advise, if you have to extract a molar tooth, slice it, take single by single, and preserve the interradicular bone, because future he might come back to you to place an implant. So that is how it is. And in my practice, I prefer placing implants most commonly about 10 to 11.5 in size. I don't generally go beyond that unless otherwise is canine, with the thing in mind that IR sir will always say, like, you should have some bone there. Even if this fails, you should get, because if you have a canine, you have 15, you will always get carried away to keep a 14 length and keep it, and you think that it is so strong it will stay for lifelong. All this occlusion and the force will take up only in the 3 millimeter or 4 millimeter maximum in the crustal region of the implant. So there is no justification to give such a long implant, because if this fails, that much amount of bone is also going to go for you, because it will slowly eat away the bone till the end. But if something is happening to this implant, if it is halfway, then you will identify, you can remove it, do some regenerative, put another implant. That is possible. So keep some bone for implants. That is something which I try to follow. Of course, I listen it from my mentors and I am trying to follow that. And this is so this, if you want to generate, especially for the anterior region, the normal healing screw will not help you, because the normal healing screw will not have this shape. It will be a round. So there you will have to customize your healing screws, whether your impression coping or make a, because this patient, in fact, after extraction, the same tooth with the crown, I put a plastic, because I got a very good primary stability. I have put a plastic abutment and I placed the same tooth head into the socket. So it healed and it came like that. So this was the same crown C I have given to the patient, because patient cannot go without any tooth. So this was given like this immediately after the implant. So this created the exact, because the tooth is in the triangular shape, the central incisor, that created the exact emergence profile which I wanted to get. So otherwise what would happen? What would have happened if I would have sutured it? This would have become flat. Then I will have to try recreating. Again, it's a big headache. So it might not come how we want to, because gingiva will not listen to us. So we make something, maybe it will go upside, it will come down. So it's a problem. So if it is possible, you can try to do is that kind of. So it's not a wound. So it's a very clean emergence profile. Is what I got. This is a customized. This is an impression coping. It's a customized impression coping. I took it. This is the impression coping, but I put the impression coping inside and added composite material so that it will support the entire tissue. So when I take this and give back to the lab will get the entire inside area. So their crown will also be prepared accordingly. It has to be highly polished, because these can have some desmosomal attachments or hemidosomal attachment to the zirconia or the ceramic, which has to be highly polished. Whatever is going inside the gingiva should be highly polished. So this is a customized impression, and that is a crown which you receive. So pretty good, okay. Otherwise everything went on fine, and this is how the patient is. And the next case is an ST3. I don't have registration for this. I did this case just 2 weeks back, because from the memory card I directly put into this. And this is a consultation case. It's not my clinic case. I went for consultation, and this is how the gingiva is. And this was a CBCT plan. You can see that it is a little thin. It is not able to receive that much amount of that much big implant. But and mandatory, this is a tip. What I'm going to tell you is, I think everybody, the senior practitioners will be doing maxillary. You have to do with densa. Do osteodensification. Even if bone is there, not there, doesn't matter. You have to do, because whatever you are taking off with the drill is the original native bone. If you have to buy that, you will have to give another 5,000 to buy it. So when you drill it, automatically bone will go off. Otherwise, you will have to buy something called as osteocon and all. It is always better to have densa burst. After the pilot, it is always better to go in densa in the reverse mode, because now bone will come out. Everything is going to be condensed. Two advantage. One, there is no bone loss. Even if you think this bone cannot receive an implant, by doing densa osteodensification, you will widen the bone easily. What you see in the CBTC, usually what it happens, in the CBCT we feel there is no bone, but when you open it, you will get some more bone. The other way is very rare, because they will maximum put it in the bottom line only, no chance, like that only they will tell. But when you open it up, you will get some amount of bone. On top of that, if you do osteodensification, you get much more. And one more thing, it doesn't create any heat. It will condense the bone nicely. So that was one way to go it. So any maxillary case, after the pilot drill or one more drill I'll go, next everything is going to go is your densa burst. Okay. This is something which is exposed. See, there are two ways to manage this case. While placing itself, you can maybe place it further deep and submerge the implant, but I don't usually do it because then the prosthetic part is going to be very, very tough. Then maybe foot lodgement. So I kept it this way at the bone level because beyond the CEJ of the adjacent tooth, maybe 1 mm, 2 mm is okay. Going too deep, I don't think so. Several says it's a good idea. So I grafted it there. And I grafted it, place a membrane, I close it. I don't know how it will come. Maybe one day when I come, I will present this case after taking the CBC. This is a xenograft. This is not allograft. This is xenograft. This is from Nova Bone, not the putty one. The xenograft. And always when you keep a graft, you have to place a membrane. Whether it is a normal membrane, what the collagen membrane you get, or you want to keep a PTFA, non-resorbable membrane, anything is okay for you. But you should have, because if these particles come and poke into the soft tissue, it can cause dehiscence. You would have seen in your grafted case, after some point, one graft particle will slowly peep in and come out. The patient will come with a white particle down it came, because it will be acting as a foreign body. Sometimes the soft tissue, because it is little sharp, the soft tissue dehiscence can happen. So when you are putting particulate graft, always it is better to cover it with membrane. Okay, at least the membrane which will stay for at least short time. So that's the future. Again, the next case. Yeah, next case, all these two. This is not very clear because too bright. All these areas there is a lot of bone loss. It is like an what ST3 case. Yeah, I think it's a ST3 means lot of label bone is gone. Okay, for this patient, can you see that? A lot of. I have a video of this, but I didn't put it because it's a little long. Because when I was removing the tooth itself, I lost a little bit because that bone was very thin and sticking onto the tooth. That also is lost. I picked it up and put it as a graft. So this is what I place, and this is little too subcrustal. There is no way otherwise I can place implant. You don't know. Maybe you can do a regenerative procedure, put a lot of graft, and call back the patient after 6 months. But the patient was not willing for that. So we said we'll try it. We will try to regenerate something. Yeah, I think. Yeah. So this is the X-ray. You can see that this is clear in this IUP. You can see that the labial, a lot of labial bone is lost in all this crustal bone, interdental bone, everything is lost, and this is not very clear. You can see that here some of the threads are exposed, but you have a jumping, you have a pocket. If you have a cavity kind of thing, always the graft will stay there. Rather than just placing on the surface, it might not stay. But if you have a concavity, always there is a chance that the graft will stay there and will pick it up. Yeah, so that was there. This was the patient's clinical picture. I think this is the clinical picture. That was, then a temporary was given, the S6 bridge was given. And that is how it was, and that is how the implant was placed. And this is one thing which I didn't like it, I'll tell you. That's a molar. That is some empty slides, last minute presentation, it happens. Some empty slides.